in the sense that one of the part of this session will be coming through the speakers and not with us physically. So what we're going to do is we're going to have two presentations. The first is going to be hybrid, and the second is going to be a joint presentation between my colleague Priscilla and I. And then we're going to transition to a bit of a panel discussion. So I'm hoping those of you who are panelists that are here this morning, if there's one more of you, I'm not sure if there is, but you can take that great middle seat up at the front. So I will first introduce our virtual speaker, who is Dr. Ivy Kasirye, who is from the World Health Organization. Dr. Ivy is a medical doctor with more than 25 years experience, and she's also a pediatrician, which makes her very well placed to speak with us this morning, and has extensive experience providing technical support for child health and adolescent girls and young women programs in Eastern and Southern Africa. In the past 2 years, she's been supporting the pediatric HIV portfolio in the WHO headquarters as a consultant in the Department of HIV, Hepatitis, and Syphilis. And she leads a mentorship program in Uganda to empower young girls and women with HIV to thrive and reach their full potential. And Dr. Ivy will be providing an overview really of the WHO guidelines and supports in the area of differentiated service delivery. So I will gaze into the bright lights and hope that the IT team can press play on her presentation for us.
Good morning to you all. Today, it gives me great pleasure to provide an overview of differentiated service delivery for HIV prevention and treatment among adolescents with you at this conference. I will begin with a brief look at the status of adolescents and HIV. Globally, there are an estimated 1.75 million adolescents between the ages of 10 and 19 years living with HIV. 90% of all adolescents living with HIV are in Africa. Adolescents account for about 4% of all people living with HIV, 10% of new HIV infections, and 4% of all AIDS-related deaths. 70% of adolescents living with HIV are girls. New HIV infections among adolescents are declining. However, the decrease is slower for girls than for boys, as we can see in these countries in East and Southern Africa. It is therefore very important that we do not lose the gains made so far and double down on our prevention and treatment efforts, as a major pathway of controlling the HIV epidemic is to address this demographic with a strong focus on adolescent girls and young women, as they are disproportionately affected compared with their male counterparts. So what do we mean by differentiated service delivery? WHO defines differentiated service delivery, previously referred to as differentiated care, as a person-centered approach that simplifies and adapts HIV services across the cascade in ways that both serve the needs of people living with HIV and those vulnerable to HIV, and reduces unnecessary burdens on the health system. The principles of differentiated service delivery can be applied across the HIV continuum, including prevention, testing, linkage to care, ART initiation, and follow-up, and integration of HIV care with co-infections and comorbidities. The decision on which DSD models to adopt should be based on local assessment of needs and preferences, as well as according to 3 elements: clinical characteristics, whether they are symptomatic or asymptomatic; context, including the setting, epidemic type, HIV prevalence, and percentage of people aware of their HIV status; and the population. So why should adolescents receive differentiated care? In the initial years of rapid ART scale-up, HIV treatment was delivered based on a one-size-fits-all clinic-based model largely undifferentiated for individual needs. Differentiated service delivery for HIV treatment has become a critical component of recognizing the diversity of needs of people living with HIV, thereby achieving better treatment and retention outcomes. Adolescents are undergoing several developmental changes, and this may mean they may have limited ability to cope with an HIV diagnosis, limited awareness of their own health needs, and of the availability of services, and limited experience and confidence in navigating health services. In addition, consent requirements may restrict access to testing, treatment, and care. In order to address the challenges adolescents face with accessing services, it is important we provide them with adolescent-friendly services and linkages, scale-up mechanisms to attract and retain them in care, including outreach to adolescents, peer-based interventions, community-based interventions, other outreach services, support groups, mobile technology, social media, and call centers. We must also recognize that adolescents are a heterogeneous group of people, and their widely varying contexts means they require a more individualized approach in order to attract and keep them in care and on treatment. It is therefore critical that we engage them actively to enable them to describe their specific needs, how they want to receive services, and generally to participate in their own care. The WHO guidelines define adolescent-friendly services and the global standards for quality HIV healthcare services for adolescents. I will not go into the details as you may already be familiar with these. However, it is important to recognize that the friendliness of services provided must be perceived by the recipients as friendly, and therefore are defined by adolescents as they are the key stakeholders. HIV prevention should be provided as a continuum of care services. Adolescents who test negative for HIV should be linked to prevention services, but this should not stop there. Adolescents, especially those at elevated risk of HIV infection, should be retained and supported to adhere to continued prevention services. There are multiple HIV prevention options available to adolescent girls and young women, as well as to adolescent boys and young men, including voluntary medical male circumcision, PrEP, PEP, STI management, condoms and lubricants, HIV testing, partner or couples testing, behavioral interventions, and treatment as prevention. Service delivery to these populations need an enabling environment contributed to by national leadership, partnerships and engagement, evidence-based normative guidance and implementation guidance, legal frameworks, and strategic information for action. With this slide, I would just like to share the global targets for 2025 for prevention. I will not discuss the specifics of each target, but this is just to highlight that the targets are specific for populations stratified by risk and epidemic characteristics. Most of us are aware of the challenges of adolescent girls and young women that make them more vulnerable to HIV infection, including biological, social, economic, and cultural dynamics that contribute to early sexual debut, early marriages, cessation of education, age-disparate relationships, power and gender inequalities, gender-based violence, among other factors. The recommended adolescent girl and young women package should therefore provide comprehensive services that may have direct or indirect impact on HIV infection risk. Interventions with direct impact include HIV testing and linkage to ART, testing for partners, condoms, PrEP, PEP, STI services, antenatal care with PMTCT, and comprehensive sexuality education. Interventions with indirect impact include adolescent-friendly health services, GBV services, contraception services, prevention of child marriage, and mental health services. To note, is that these services are also critical to adolescent boys and young men. And in a bid to focus on adolescent girls and young women, adolescent boys and young men should not be forgotten. Prevention services targeting adolescent boys and young women should run in tandem, and they too need to be tailored in a person-centered manner to meet the needs of this population. Interventions not specific for HIV, but that have benefit for adolescent girls and young women everywhere include keeping girls in school, employment, higher education opportunities and economic empowerment, social protection, and menstrual hygiene. Countries should have policies in place to generate a conducive environment for adolescent services, and these include where and how adolescents can access services. It is important that services are integrated on existing service delivery platforms to improve efficiency, increase uptake, and to promote sustainability of responses. Services may be provided at facilities, pharmacies, or in the communities with mobile sites, outreach sites, and in schools. Service modalities aim to reach this demographic in different ways, including via routine services within existing health services, and through campaigns, and even take advantage of technology, provide virtual services. WHO recommends differentiated HIV testing service delivery to address the needs of different population groups, contexts, and epidemic settings. It is essential for countries to provide a strategic mix of WHO-recommended differentiated HIV testing service delivery approaches. These include facility-based testing, community-based testing, HIV self-testing, partner testing, including provider-assisted referral and social network-based approaches. Several context-specific models have been applied in different settings, responding to the specific needs of adolescents, all aimed at increasing access to testing and responding to their needs, including confidentiality, accessibility, efficiency, and linkage to other services that they need. Moving on to treatment. Globally, ART coverage for adolescents living with HIV is 65%, and it is estimated that viral suppression is approximately 60%, which are both way below the 95 targets. In order to reach the targets by 2025, there is an urgent need to accelerate treatment efforts among adolescents. Evidence shows that differentiated ART service delivery does improve retention in care, ART adherence, and viral suppression. WHO defines 4 building blocks for differentiated ART delivery. These building blocks describe where services should be provided, who should provide these services, when they should be provided, with emphasis on decreasing the frequency of visits and refills where appropriate, and what specific services should be delivered. From the schema, we can appreciate that services may be provided at facilities or in communities based on WHO recommendations to decentralize treatment. These building blocks need to be defined separately for ART refills, clinic consultations, and psychosocial support. So who is eligible for differentiated service delivery for ART? Differentiated service delivery for HIV treatment has focused primarily on people who are clinically stable. The criteria for determining whether a person has been successfully established on ART include receiving ART for at least 6 months, no current illness, which does not include well-controlled chronic health conditions, good understanding of lifelong adherence, adequate adherence counseling provided, and evidence of treatment success with at least one suppressed viral load result within the past 6 months. Specific service delivery recommendations include strong recommendations for clinic visits and ART dispensing every 3 to 6 months, preferably 6 months if feasible. Tracing and support for people who have disengaged, psychosocial interventions provided to all adolescents and young people living with HIV, and task sharing for laboratory services. WHO also makes conditional recommendations for ART initiation outside the facility, SRH service integration with HIV services, and integration of NCDs with HIV services. So why should we be giving differentiated ART services to adolescents? Differentiated ART approaches aim to improve client experience by lowering waiting time and reducing the financial burden of multiple visits, to improve health outcomes by impacting on patient adherence and retention, allows clinic services to focus attention on unstable adolescents and patients who need clinical care. And it also allows services to harness the benefits of task shifting and task sharing. Broadly, WHO describes 4 categories of DSD-ART models. There are individual models based at facilities, for example, fast track, pharmacy visits, quick pickup, flexible hours, and adolescent clinic days. There are also group models based at facilities, for example, facility ART groups, like facility-based teen clubs. There are group models based in communities, for example, community adherence or ART group clubs, groups or clubs, for example, the community teen clubs. And individual models based in communities, for example, community pharmacy or pickup points, mobile clinics, and home delivery. These models can be adapted to adolescent-specific models, and indeed, many partners have developed different approaches to achieve adherence retention and viral suppression in adolescents. Despite its many successes and advantages, there are still challenges to differentiated service delivery implementation. Health systems issues, including supply chain, access to viral load testing, M&E systems, and human resource capacity remain challenging. There is limited expansion of community DSD-ART models and reluctance of healthcare providers to reduce the frequency of visits for adolescents. Another challenge is the lack of access to routine viral load monitoring. However, there have been several efforts to address these gaps, including engaging providers and communities to create demand and involving them in quality assurance and improvement. Improvement in supply chain, which doesn't only benefit differentiated service delivery implementation, but the entire HIV cascade. Adaptations as a result of the COVID-19 pandemic, which resulted in longer-term opportunities, including integration of other services and transition from 3 to 6 month supply of medications in the communities. Engagement with peers and community platforms has been an opportunity, and designated adolescent and youth-friendly spaces and planned transition of adolescents to adult services have also been facilitators of DSD. Clinic flexible hours and consultation days outside of school hours and during holidays, and family models of care have been other ways in which partners have overcome the barriers of DSD. We do, however, recognize that ART on its own is not a solution to viral suppression. Key to the successful outcomes of ART are adherence and retention. There are WHO recommendations for differentiated approaches to support adherence, retention, and re-engagement in care that you can also find in the consolidated guidelines. These recommendations promote interventions that support adherence, including peer programming, use of mobile phone technology, cognitive behavioral therapy, and use of fixed dose combinations and once daily regimens to promote adherence. Programs should provide community support to improve retention in HIV care. And finally, HIV programs should implement interventions to trace people who have disengaged and provide support for re-engagement and create those community care linkages. As I conclude with these last two slides, I would like to highlight two important approaches for adolescent health. The first is the peer approach. There is ample evidence to show that this approach is effective across the continuum from testing, prevention, and treatment in improving access, adherence, and retention. WHO strongly recommends the scale-up of this approach. Finally, mental health is a priority for adolescents living with HIV. WHO recommends that psychosocial interventions should be provided to all adolescents and young people living with HIV, and it is key that these interventions are integrated into adolescent HIV service delivery. And with this, I have come to the end of my presentation. I thank you for your kind attention.
Thanks very much, Dr. Kasirye. So I believe she's also online and joining us virtually. So when we get into the panel and discussion, I will do my best to see if we can engage her in that conversation. So if you have questions, we will engage her then. So the next presentation is going to be by my colleague Priscilla and I. So I'm going to introduce Priscilla, and then she's going to come tag team, give me a high five halfway through the slides. So Dr. Priscilla is a technical lead of the Collaborative Initiative for Pediatric HIV Education and Research, or known as CIPHER, which is the pediatric and adolescent program of IAS, the International AIDS Society. She's a medical doctor by training, holds an MPH from the University of Cape Town, and is currently completing her PhD, which focuses on the transition of adolescents living with HIV to adulthood. And so makes her, again, really well placed to speak with us this morning. Previously, Dr. Tsondai worked at CIDR at UCT, as well as at Pangora's Group's technical support services, overseeing their HIV prevention and treatment, strategic information, and global health security portfolios. And I'm personally just so happy that Priscilla has joined IS and will be leading our adolescent and pediatric work. So I'm going to take over from where Dr. Kasirye left off. And what I'm going to do is try and make some of those WHO recommendations come to life. So focus a little bit more on some case examples. And then what I'm going to do is hand over to Priscilla, who's going to talk a little bit about PrEP and innovations. And this was the part that her and I discussed quite a lot, obviously, given the thematic of the conference that you're all at today. So we're going to place a little bit of food for thoughts, and I'm looking at Yvette, because originally Yvette's session was before ours. So we're going to plant some seeds for you all to think about in the session later on today about how we need to talk about people, not just products, and see if we can get you thinking about that and its relationship to differentiated service delivery. All right, so you can go to the next slide for me, please. So or can I go myself? Oh, I probably can. Okay, great. So Dr. Kasirye talked about this, and what we want to emphasize here is that differentiated service delivery has been a WHO recommendation since 2016. And the timing of this is important. You'll recall that in 2016, WHO recommended everybody living with HIV be supported to initiate treatment. And so we knew that a one-size-fits-all approach wouldn't work. And so this was part of their efforts to ensure that everyone had access to antiretroviral therapy. And DSD really has to have this balancing act where we're acknowledging the needs of the individual while also accepting that they're operating in often a resource-constrained public health system. And it's important as well just to note that this is, as was mentioned, applies across the cascade. So I'm going to talk first about treatment. We're going to talk a little bit about prevention, and Dr. Kasirye mentioned how it's also relevant for testing. So next slide. We also really want to say that there are challenges. So you can see from these two illustrations, the first person saying, how am I supposed to test for HIV every 6 months? Why am I going to go to a clinic to do that when there's different ways for me to access testing? And what's this PrEP thing, and how can I get it? And then you'll see from this couple, they're saying we both have an undetectable viral load. So why are you not giving us more treatment so that we can have sustained retention? Why do you need to see us all the time? And I think especially for populations and providers that are working with adolescents and even more so with children, we have to start to challenge the assumption that seeing people more is helpful, right? So there's a desire that we keep them in our clinic, we see them all the time, and that's really helpful because we have our eyes on them, we have their hands on them. But what are we offering them that's so important that we need to see them all the time? And why do they need to come to us for that to happen? Should we contact them in different ways? Could they get some of that support from their peers? And I'm always reminded of the quote that if your teacher asks you how you're doing, what is your response? Versus if your friend asks you how you're doing, what's your response? And that degree of honesty, that degree of trust, and that's exactly why we need to involve peers more in services. Next slide. We also need to know that it's not just HIV that is people's priority, right? And I liked that this came up a lot as well in Linda Gale's presentation. We know that young people living with HIV want to talk about more than just HIV and have health needs beyond HIV. And we're going to highlight some data later on that kind of shows the failure in some ways of providing sexual and reproductive health services despite innovations that we have with products as we look to new products in HIV treatment and prevention. So we want DSD to not just be HIV specific. We want to talk about DSD for SRH. We want to talk about DSD for NCDs. We want to see this approach become part of the public healthcare system. So next slide. We've mentioned this, but DSD applies not just for treatment and testing, but also for prevention. So I won't go on and on about this, but I think what's important here, and maybe it's a subtle thing, is that you'll note that the word re is here. So we need to relink people to services and relink people to testing. And we have this really nice idea, right, of 95, 95, 95, and that's all linear. And I can explain that to my mom, and then she understands what we're doing in the HIV response. But people are cycling in and out of our systems all the time. We don't want to talk about that, but we know that people have treatment interruptions, maybe have gaps in their prevention commodities. And so we also need to acknowledge that as a health system and health providers as how we support people when they return instead of punishing them when they return. So I think beyond this, we got to talk about that relinking, re-engagement, new support. Okay, so next slide, DSD for HIV treatment, and next slide again. Dr. Kasirye mentioned this. So differentiated service delivery has primarily been for people who are established on treatment. I'm not going to call them stable because nobody wants to be called stable or unstable. And you can see here that many people are now eligible for DSD for HIV treatment. And if you hit next, this was a big shift because WHO said DSD for HIV treatment is not just for adults that have no other conditions who've been on treatment for a long time. It's also available to those who are on second, third line regimens. It's available for those who have controlled comorbidities. It's available for children, adolescents, for those who are pregnant and breastfeeding, and for key populations is probably hidden somewhere there. But this is an approach that now we need to expand and offer not just to one part of the population. And so there's been a huge emphasis to make sure that it's not just adults who are benefiting from differentiated service delivery. Next slide. And we also know that we can adapt these building blocks, right? So when you think about your service delivery model, think about the when, where, who, and what. And also think about how this differs for clinical consultations, for treatment refills, and for psychosocial support. So the providers that can offer clinical consultations are much different than the providers that can maybe offer psychosocial support. And the venue that you offer that is different, and the modality and the frequency and all of those things. So let's think about this package of care in this differentiated way where we adjust these building blocks depending on clinical consultation, psychosocial support, and treatment refills. This is interesting and even more relevant. I think just by show of hands, how many of you work primarily in South Africa? So you'll see some name and shame slides later in terms of how slow we are at scaling up longer ART refills. But this is really important here where we can't get very long treatment refills. So do we need a clinical consultation every time someone needs a drug pickup? That's the question, right? And so we'll look at that. So here on the next slide, you can see the 4 models that are endorsed by the WHO in their treatment guidelines. So group models managed by healthcare workers, group models managed by clients, that's really important. and then the facility-based individual models and the out-of-facility-based individuals. So going from the top left, if you hit next, these are our teen clubs that happen at in the community or in a facility, but have a healthcare worker that's providing the convening the group. Doesn't necessarily need to be a clinician, but there's someone from the healthcare system that's supporting that. If you hit next, we've got group models that are managed by clients themselves. If you can hit next. Yeah, so these would be things like family treatment groups. And again, those would probably meet in community, but could meet in a health facility as well. And then next, you've got things like your fast track pickup or your adolescent corner. And finally, next, you've got out of facility models. So this could be young people collecting treatment refills from a pharmacy, from a van, from a locker, etc. And you'll note here that we say that multi-month dispensing is part of it, but not the whole story. This is maybe for later as a reference. So when I talk about DSD, I'm talking about it not just for treatment. When people talk about DDD, they're generally talking about decentralized drug distribution or where you get your drugs from. And we know it's not just about drugs. So that's one specific component, but let's not conflate DSD and DDD. If someone's speaking about multi-month dispensing, they're speaking about the number of months of a refill dispensed compared to multi-month scripting, which would be how long is their prescription for. So you could have a prescription for 6 months that allows you to get 3 times 2 pickups, for example. So that's just more of the language. And then Dr. Kasirye also talked a little bit about adolescent-friendly services. And I would hope that our services are friendly in general to adolescents, to key populations, to people regardless of gender, age, sexuality, etc. So again, I wouldn't say adolescent-friendly services and DSD are the same, but hopefully our DSD services for adolescents are friendly to their needs. Okay, so here are some examples. Next slide. The first is probably the best known. So these are teen clubs. And what a teen club generally means, and this is why it's important to describe it, it's a healthcare worker managed group. So that means that there's someone from the health services who is convening this group, maybe a clinician, maybe a nurse, often a community healthcare worker. So someone from the systems involved. The same group of adolescents are meeting every few months. They're receiving adherence support as a group and providing adherence support as a group. So there's a peer engagement model. And in that model, hopefully they're also getting their pre-packed medication. So they're hopefully not having to go to their teen club and to the pharmacy, because that's a waste of everybody's time. And we see teen clubs have huge pickup in different regions. We also see them happening out of hours on weekends and showing good clinical outcomes for the people who are in them. All right. Next slide are adolescent groups. And this is a screenshot from the operational and service delivery manual in Zimbabwe. And there's 2 things I want to highlight here. The first is that this is exactly from their guidance. So they have building blocks in their national guidance, which I obviously really like. And then the second is that if you look on the gray boxes, you'll see this acronym CATS, which stands for Community Adolescent Treatment Supporter, not like Halloween cats or household cats, right? And these community adolescent treatment supporters, they're in the national guidance. How awesome is it that there's adolescents that are part of the healthcare system in Zimbabwe's guidance? And they're given roles and responsibilities, not just psychosocial support on the far right, but also they're allowed to provide treatment refills. They're not clinically providing refills. They're not dispensing medication. They're distributing medication. And so this is a great example of how adolescents can really be part of the healthcare system. Next slide, you'll see we have adolescent corners, and hopefully many of you are familiar with these. This would be a safe space generally within a facility-based individual model, where people have an adolescent-friendly provider that is giving them the care and treatment and support that they need on specific days. And again, really good outcomes for facilities that provide these. And we see that adolescents vote with their feet. So if they know there's an adolescent-friendly corner, they'll travel from further to come and be part of that. And so I think that's also really important in terms of how we design our services. All right, on the next slide, I won't go into this in too much detail, super confusing. What you need to know here is the teal blocks are national guidance. The orange blocks are what countries did during COVID. And the number in the middle looks at what age group somebody is eligible for this length of refill. So if you look at South Africa, which is alphabetical, you'll see that those who are 2 years and younger are excluded from multi-month refills, and those who are 5, 10 years of age and adolescents and adults as of 2022, could get a maximum of 3 months dispensing. And what I want you to acknowledge is all the countries that are on the other side of South Africa. The majority of South Africans are still getting 2 months dispensing. And I'm going to show you data next about what's happening in the region. The first, though, is just to say that dose changes are rare in children aged 2 to 5, for those of you who are nervous about this. So if a child is established on treatment and doing well, they don't actually need to be weighed all the time for their dosing to be adjusted. So it's back to my point on why are you bringing them back to the facility? Is it just to weigh them? And how often do you really need to weigh them? If their caregiver is being provided 3 months dispensing, wouldn't it be beneficial for their child to also be aligned and have the same frequency of refills? So let's just think about that for a little bit. You can go next and then next. So here, this is PEPFAR data from 21 countries, excluding South Africa. So if you just look all the way on the far right-hand side, as of a year ago, there was 11+ million people that were getting 3 to 6 month dispensing globally in PEPFAR-supported programs, or almost 6 million people who are getting 6 month dispensing. 6 million people. And in South Africa, we have more than that living with HIV and no one getting 6 month dispensing. So just a data slide. And if you hit next, you'll also see that this includes people under 15 years of age and younger. So in red, you can see, look, there is 88,000 people 15 years and younger getting 6 months, and 260,000, or half of this cohort, who are getting 3 to 5 months. So this is also for younger people, this is relevant, also for that family-based approach. And so we really need to look at when it might be beneficial to give people longer treatment and help us to trust one another if we're providing them with those sorts of services. All right, I'll pick up more in a bit, but for now I'm going to turn over to Priscilla, who's going to talk us through prevention and innovations. Thanks.
All right, thank you, and good morning to everyone. Thank you so much. All right, so DSD for HIV prevention. So what we know is that PrEP works, oral PrEP works. It has been proven to be safe. It has been proven to be efficacious. It has been proven that it can be dispersed to people of all, of all sexes, gender, race. So what we know is that oral PrEP works. Now the question is, what do we need to practice? Who has access? Everyone must be familiar with this slide. I actually took it from your Instagram page. And this slide is just showing us, right, that although oral PrEP is known to be highly effective and safe, why has it not reduced HIV incidence in South Africa to the extent that is seen in the other countries? We are excited, and I'm hoping the next session will then talk a bit about the other PrEP products that are now available for us here in South Africa. We need to also keep thinking about the effective and persistent use of those products for South Africa to actually see the full impact of PrEP. WHO, as Ivy has mentioned, supports differentiated PrEP. So I will not go into detail here. We'll then move over to just some things we need to keep at the back of our mind as we talk about HIV prevention, as we become excited with the new products that are, being released and the new products that have been licensed. And this is talking about the long-acting products. And we heard at the international workshop on adolescents and HIV that adolescents are not in the box. So thinking outside the box is actually not an option if we want to, reach that population. So thinking about long-acting PrEP or prevention products, we need to just not think about the product, but also consider where and how. We will need to really think outside the box in terms of delivering an intramuscular injection to the gluteal region every 2 months to these young people. That will need some serious thinking outside the box. We will need to also think about how we've come so far in making, the healthcare system trust that actually these medicines can be delivered out of the facility, can be delivered by non-healthcare workers in terms of trained. We actually also need to rethink when we're talking about these long-acting products in terms of, do we not then risk remedicalizing access to these products. Integration. It has been proven that, the PrEP products do not, in a pharmaceutical way, sort of interfere with hormonal contraception. We need to think about how it can then be co-formulated. As Dr. Grimsrud talked about, aligning the prescriptions for the mom and her baby. What about also just lining up so that if I'm getting an intramuscular injection, I'm getting one for both my contraceptive needs and for my PrEP needs? And as Dr. Grimsrud highlighted, DSD is not just for HIV prevention. We need to look at individuals as a whole, not just talk about HIV prevention or treatment. And this for me is like best case scenario. We are so excited for the 2 monthly intramuscular injections. How lovely would it be for a 6 to 12 monthly? Something that is longer duration, something that is less invasive that I can do in the comforts of my own home. We're excited about the vaginal rings that have also been, licensed, something that I can also self-administer. So those are just some of the questions we want to pose out there. This is just a code highlighting that it's about people having options, it's about people feeling in control, and hence why it's important for those options to be available. We're using this slide. What we just want to highlight is using contraceptives as like an analog for, PrEP preference. Now we're going to use it for like an analog of what the healthcare system needs to really set up so that when this becomes available and is scaled up, are we not at risk of then running into these same issues? 17% of 373 health facilities within South Africa reported contraceptive stockouts in the past 3 months. And if you look at which contraception method had the biggest problem where stockouts was concerned, it's the injection. Looking at this slide, I want you to concentrate on the very last cluster of bars, which is the national average. And if you look year on year, you can see that there is a very steady increase in the rate of deliveries in 15 to 19-year-old adolescent girls, and over 3/4 of these pregnancies are unplanned. That's an unmet need. Again, the point we're trying to drive home is it's not just about the product. We need to make sure we're thinking about how we're going to get it to those who need it, how we're going to get it to the adolescent population. These are now just resources for you to then go and read that talk about the long-acting extended delivery regimens for HIV prevention and care. And the key takeaways here are that adolescents and young people should not be left out where DSD is being discussed, especially for PrEP and for HIV treatment. We do have examples of group and community-based models that can be considered, and we do have data that highlights the impacts and the outcomes. Adolescents and young people can also receive multi-month dispensing and have been shown in other cohorts that they still achieve the good outcomes. And we need to address the service delivery challenges that are associated with integrating contraceptive and sexual and reproductive health care into HIV prevention and treatment. And then these slides, I hope, will be shared. We also added some resources that the team at the IAS has put together for courses on DSD, to watch videos, to hear the voices of the youth. And with that, I say thank you.
So we'd like to invite our panelists to join Priscilla at this table. I'm not sure exactly who's here. I do have bios, but I always think it's slightly more impactful for you to just introduce yourself. So you've heard a bio about Priscilla and I. I'm just looking to Melissa.
Sorry.
Yeah.
Yanelisa and Apilele, would you like to join the panelists up there at the table? Thank you.
So with us already is Pamela, is that right? Okay, good morning, Pamela. Pamela Fuzile is the retention officer for Fast PrEP. And she's been working in HIV programs for over a decade, providing counseling to young adolescents, including running intervention sessions in group settings. That's you?
Correct.
Excellent. And then also we have Yanelisa, is that right? Good morning, Yanelisa. Would you, please go ahead and introduce yourself. I don't have a sufficient bio for you. Would love to hear who you are.
Yanelisa Khati ngisuka eKTC the patient and I'm 24 years old living with HIV.
Thank you, Yanelisa. We look forward to chatting with you. And Apelele.
Good morning, everyone. Sitting in front of you is Apelele, all the way from Philippi, but receiving the treatment from the Kukuletu Day Clinic. I was diagnosed with HIV. I think it's on 18th of December, 2018. So since then, I've been a patient. Thank you.
Thank you. Lovely to meet you both. So that was the cue for everyone to now get slightly involved. But before I turn to the audience for questions or comments and discussion, I was wondering if any of the panelists had anything they want to reflect on after hearing Linda Gale's presentation, Dr. Kasirye's presentation, and from Priscilla and or if I would be really interested if you could kick us off today on your thoughts on DSD for young people.
There were great presentations. Thank you so much. And I think we are all learning that when it comes to serving young people, there is no such thing as one size fits all. And there are actually aspects in their lives we should really learn to consult with them and find out how can we best deliver services to them or for them.
Excellent. Thank you very much. Okay, so I very much want to acknowledge that it's a real privilege to have people who are users of the healthcare system, who are recipients of care, who are young people themselves living with HIV and accessing treatment. So I want to make sure that throughout this session, you feel free to contribute and share as much or as little as you want to. And so Melissa's given me some background, but depending on what you would like to share with this audience, do you think that what was missing from our presentations? We don't need thank you for the thank yous, but we'd love to know from your perspective, what does DSD for young people actually mean? What has your experience actually been? What would you like those of us in the audience to know and hear from you today from your lived experience?
That's for me.
No, I think it's for Yanelisa and Mpebelele.
DSD means for us to get medication while sitting at home. During COVID, all know that clinics were full and clinics were closed. And for us young people, we are ashamed for our neighbors or friends, what they will say about us. So it was much better getting medication from home. And most of us don't like people. What will say about me, or what will do about me, what will say about me living with HIV at this young age. So it was very nice experience getting medication from home, especially for most of us. Yeah.
Great. So you had a specific experience during COVID where you no longer had to go to facilities to access antiretrovirals. They were couriered to you in the privacy of your own home. Is that correct? Okay.
I've been visiting the clinic for my medication, so I don't have any idea of how it works. But I think it is a good idea for medication to get delivered to us as peers, because some of us, but before I say that, there are advantages and disadvantages of that. The advantages that some of us as peers don't like visiting the clinics And the other disadvantage is that some of us don't really want our neighbors to know that we are living with the sick. So there is an advantage of it, there is a disadvantage of it. So, but I think if I was not getting an injection, I would also prefer the delivery because there is a long queue there. You still have to go to the pharmacy again and wait for long for your medication. So I think it's a good idea.
Great. So maybe just keep the mic for a second because you mentioned, and if you're happy to share with the group that you're currently receiving an injectable treatment option. Could you share more about what that's been like and where you go for that?
I think I started last month receiving an injectable treatment. I think it is the best option for us in youngsters because most of the times we're busy. Sometimes we forget to take our treatment. Let's say the doctor said to us we must take our treatment at 8. So sometimes we forget to take that. Let's say we're going to work and we're late or going to school, we're late for school, so we forget to. So the injectable treatment is the best option. Or for me, it is the best option because I don't have to stress about taking the pill every day. Even if I went to visit my family and forgot my medication at home. So I don't have to stress much about it because I already have an injection that lasts for a month or 2 months. So
great. And then maybe for Pamela, I'd be interested. We've heard from the two young women about their experiences living with HIV and the pros and cons of accessing services at a health facility. What's the experience of fast PrEP in terms of people wanting to be on PrEP, people wanting to be associated with PrEP? How's that been going?
It's been good. But again, I'm hearing common challenges like young people not wanting to go to the clinic. And I'm thinking to myself, we are so cool with doing deliveries. But with fast PrEP, there is that option where they don't necessarily have to go back to our clinics or to go back to the mobile. They can get their PrEP delivered. And I know that LGB really also wants us to be at pharmacies where they can go to clicks and get their PrEP. But we also have youth clubs. We have the quick depots starting next week. So yeah, we really want to be accessible to everyone.
Great, thanks. Sounds like lots of options and lots of choices, lots of work, but worth it to expand the access. Okay, great. So I saw one hand from the audience, and I'm gonna go and physically hand a microphone so that the people online can hear. But I just preparing, not prepping, the rest of the audience for any questions. And then I'll also turn to Dr. Kasirye to see if she's online, but go ahead with your question. Thanks.
So it was actually linked to the slide that you put up, which
Okay.
was just what happened to the refills during COVID. And in South Africa, it looked like there was absolutely no change. And it was still 2 months. Is that correct? And so my question was actually just for Pamela and the two young ladies. But you actually answered it in part. Just did you find that how were you struggling during COVID itself? Actually, if you imagined yourself to maybe be at work, would that have changed your acceptance of what the option was? Like that, you were now getting your medication delivered to you. Do you think that would have made you feel less comfortable or more comfortable about the solution? Do you have any friends maybe who were like essential workers who now weren't home for their medications being delivered? Something along those lines, if you'd like to say anything.
Okay, during COVID, we all know clinics were full and people were queuing outside. And then most of us youth will go to schools and go to work. And then you just wake up to take your date for the next appointment and then go home, get your medication delivered and then you sign. And those people who are delivering medication, they're not from the clinic, they're just strangers, it's little strangers, and the car is not written Desmond to HIV Foundation. Just knock and just, hey, I'm looking for Yanelisa, and you just sign, and then they'll go. And my community, they never noticed that they were someone medication.
You were just getting a visitor for some reason. And was that the same if you got like injectable contraceptives as well? Was that also done at home? So you know why I'm asking this is because I know from the TB clinic experience, I used to work in Delft, and I just remember the queues of people around the clinic and what a huge issue that was for people to get their daily TB treatment, and subsequently what happened to our TB treatment rates. And I'm just wondering, like, do you know friends, perhaps you obviously were, okay, you made a plan, you kind of stuck with it and you were connected, but for how many of your friends or people that you knew about who actually fell out of treatment in that time, and like the reasons maybe why it wasn't working? If you could say something about that.
There were a lot. I lost most of my friends during that time because most of them they were like, I'm not going to care what people will say about me. Because I'm HIV, I was born with it. And most of our mothers in clinic, they'll say, why is she doing here? You take pills. She obviously open her legs to get HIV. Meanwhile, we're not doing that. We're born with it. So most of my friends just like defaulted and then they just died. At least 2 or 3 of them, they just died.
Want to talk? No. But do you want to extend the mic?
Back here. Okay, are they on?
Good morning, and thank you for this opportunity. My name is Maureen. I'm from FAM Crew at Stellenbosch University, the Tygerberg campus. I'm also a peer educator for adolescents and have been for the past 15 years. So in essence, I'm very passionate about adolescents. The first thing that I want to mention is I want to thank the lady in front. Thank you for your non-stigmatizing language when you refer to, saying stable or unstable. We all know, I don't know if most of you are familiar with the glossary of stigmatizing language, which we have been trying to do away with, especially when it comes to research. And the reason why I'm saying thank you is because we know how adolescents feel when they are referred to as being something which they're not comfortable being. So thank you for that. The other thing that I want to allude to is in the first slide, I think this first slide, yes, where it mentioned about HIV self-testing. I like that, but I also am not immune to the fact that it comes with a lot of issues that we sometimes tend to overlook. While HIV self-testing is great, along with that greatness should come the education of self-testing, and specifically more so in adolescence, because now we're looking at a whole dimension of adolescents themselves, and that is their behavior. How is an adolescent that is going to do self-testing react when they find out that they are positive? So what measures do we have in place to address that? Because now we're looking at a broad spectrum of things, and this includes suicidal tendencies. And then last but not least is on the presentation that was done by Dr. Ivy Kasirye, sorry. We still have a lot to do to bridge the gap between HIV/AIDS research and standard of health care. While I do acknowledge that research for its specialized care of study participants, I still would like to see a lot more being done in terms of transitioning our adolescents from the research sector to the standard of health care, because that gap is still too wide. So in addition, the transition education should be an ongoing process to get adolescents well braced for the different environment which differs from research type of care. Thank you.
Great. Thanks very much for your comments and questions. I would say one of the challenges we've had with DSD from the beginning is that, and I often think about this actually just in terms of adulting, where we have to hold two conflicting thoughts, seemingly conflicting thoughts in our head at the same time. So we want to empower people to make decisions for their own health and have self-care options. We also don't want the health system to be obfuscated of all responsibility and make it all the responsibility of the person, right? So we have to strike that balance, and that comes with education, health literacy in general, and also knowing and ensuring that people have and understand their rights to healthcare, their right to information, their right to show up at a facility when they don't have a scheduled appointment. So we've got to do both, and there's a challenge there. I understand there's some questions from the online audience, and so I'm looking to see if there's a way in which we can read some of those out. I think we might need a microphone, is that right? I don't have access to the online system here. Oh, okay, sorry. Just if anyone does, please feel free to put questions in, and we will make sure that they're addressed. Otherwise, I saw a hand go up in the relative front here, if we can get another microphone. Thank you.
Good morning, everybody. My name is Paula Tatubana from the Desmond Tutu Health Foundation, the LGBTI division at Khati. So my question is to Pamela and the doc as well. So Fast Prep and DSD, like I'm just quite interested, in fact, curious, what has been the intake level, speaking of adolescent, because, you know, when we're speaking a vulnerable population, we're also talking about, you know, gender diverse youth. I'm quite interested, what has been the level of intake, you know, from your services towards the LGBTI community, and like what are the challenges, especially the gender diverse youth, and how have you been navigating that?
I'm not sure if I got your question correctly, but if I understand, you're asking how are we providing services to the. Is it, oh, I would give it a 50-50. Because we also realize that we also have a lot to learn when it comes to the community. We've also taken steps in terms of our education material and also getting people that are in that community. So if you look at our peer navigators in the clinic, we have a representation, including our mobiles, as a representation of the LGBTQI community, because we know that they should know better than teach us most of things. But we also learned just a few weeks ago that our services is not really speaking directly to that community. Yes, we are youth friendly, but not necessarily, I don't know how to interpret it, but they don't really feel us, really. And we are taking steps to learn how we can best serve them. Yeah, thank you.
I see you next.
Hey guys, I'm Cal Bruns. I started a little company called Matchboxology that's worked with Desmond Tutu and lots of others over the last 15 years on issues like this. And thank you, ladies, for coming and being open to answer questions today. I want to ask you a little bit of a different type of question. If every person in your community understood viral suppression, understood the benefits of ART, do you think that would reduce the stigma that you feel in going to access the drugs?
So while I'm coming, I'm gonna just say it again. So we all know undetectable is untransmittable, right? So I think what Cal's saying is, if everybody really understood that by taking their pills, that virus is completely suppressed and undetectable, that people would feel freer about coming for their treatment. Do you understand what we're saying? No.
I think Yvette's trying to help you out too here, Linda Gale.
Okay.
That's what I took the hand to mean.
But I love this. I'm getting my steps in.
This is your MPLO.
Okay, thank you so much. Good morning, everyone. Sanibonani bantwana bam, ni right? Yes. Carl, nice to see you. It's 20 years and I sit here with my medication. I take it, but it is the fact that this disease is mainly sexually transmitted. It's the fact that a young person born with HIV has to explain that I'm taking this because I was born with it. As she was speaking, I was feeling it. If I don't say something to this young person, it's okay. First of all, we don't have to explain it, but that's not the meeting, right? It's not the education. But I think more than anything, young people are trying to tell us that we can do all of these things, but you will come look at an Yvette who's confident for 20 years and say, why is everyone not like that, without thinking around their challenges. So I think the education is not only to us, but it's to those around us to say, it's okay to ask me, why are you taking your medication this time? I'm also struggling. I had a whole ETV come visit my life because I know the mental health challenges of taking ARVs, the mental health challenges of sitting, wanting not to go to the clinic, but somebody sees it first to give me only 1 month. And I don't want to go to the clinic. My challenge is not, can I get to the clinic? My challenge is, I don't want to go. I don't want to stand in a queue and with 50 people while I have a report waiting, but I still get 1 month, every month by this scam from my doctor. So a lot needs to be done for us to change it for people living with HIV, but I don't want it to be the challenge for young people. Young people should not be getting HIV. Thank you.
No. I want to add anything. Does anybody want to add anything? I don't want to throw Cal. Maybe the question should have been to the community at large. Would we have a better attitude about disease in general, you know, if we understood it better? And one of the important lessons that needs to come through, and maybe, you know, this isn't the forum, but you know, if your virus is undetectable, you are uninfectious. That is now, in case you haven't seen, WHO has now come out with a policy statement. It is 0. Your risk of transmission is not maybe a little bit, it is 0. You will not transmit to somebody else. Okay, so that we all need to own, and then maybe move our attitudes forward as a community, whether we live with virus or not, we need to move it forward. I don't know if anyone, Pam, because I heard a question about self-testing and I want to just pick up on that. I'm going to ask Pam to pick up.
Yes, so we offer a self-test on our courier service, and your concern is valid. However, young people are not as, I don't know how to put it, before they are given the self-test, they are well educated of the results that they can expect, and they sign up for this, that this is what they are prepared to do on their own privately. So if their test were to be HIV positive, there's also steps that they can take. They are well covered or protected. They would not be left alone just because their test was done at all. And they are capable. Just because they're young people doesn't necessarily mean we have to baby them all the time. They are capable of doing these things on their own.
So back on the U equals U question, I think that maybe it's a question for everybody because, you know, the community of people living with HIV is has had great involvement in many ways in the HIV response, understands HIV very well historically, but the broader world doesn't, right? So like when I talk to people outside of public health about U equals U, I have to go like way back. Like their treatment education in HIV is so minimal. So I'm almost not sure where we need more information, we can always benefit, but the broader group needs to kind of get accelerated into more access to information around HIV, the broader community. Yeah, I think they're still in the 80s and 90s largely about HIV and understanding all the rapid changes that have happened over the past 2 decades. I see 1, 2, 3. I just want to pick up the online question, which I got via Melissa, which is around integration of differentiated service delivery within schools. And are we using schools as a venue? I will see if there's anyone on the panel. I will also say in a country like Zimbabwe, the other thing that's interesting is that many learners in Zimbabwe go to boarding school. And so they have worked within their guidelines to align the visit frequency with school holidays to ensure that people can access facilities that align with term breaks, and they're on a 3-term system there largely. And so that's why they have 4 monthly refills, which looks a bit funny, but it's not, it's context specific. They've actually looked at when it makes sense for adolescents to come. So that would be one example. Otherwise, where was the first hand? Oh, great, thank you, go ahead.
Thank you for the amazing, insightful presentations. I just have one question connected to the comment that you've just made. As someone who comes from a rural area where poverty is deepest, opportunities are least, information is less accessible, what steps are you guys taking to making sure that you disseminate this insightful, rich information to those communities? Are there any branches within the rural areas? Is there anything at all that is being done to make sure that they are also being taken into account in these tailored strategies? Thank you.
Brilliant question.
Great.
Should we get
take a
few?
couple? Yeah.
Yeah. Okay, here, I'm coming.
Great.
Hi, my name is Nombulelo. I was just wondering, it's actually quite linked to what she was saying, specifically in terms of the education in rural areas, especially areas where courier, etc., is not something that's actually accessible. What are some of the intervention strategies in those spaces? And then the next question I had was, when it comes to the education of young people around HIV and some of the new things that come up almost all the time, I was just wondering how much of that are we integrating into specifically our education system, and what is sort of the communication in that regard?
Another brilliant question. Anything on the right-hand side of the room? We've got you there. We're going to do, let me do here and then I'm coming back to you.
Good morning, everyone. My name is Yanelisa, and my question is somehow connected to both the ladies in terms of access to communication. I was wondering if it is possible for youth to be more involved in the information in like things like podcasts, because that's where you find youth. You understand? Like it's so rare to find young people in such spaces, but go to YouTube, go to Spotify, and you understand? So could it be possible for this information to be accessed there and for young people to be actually interacting in such spaces? Because if someone who's like 10 years or 20 years older than you can, when someone older than you is informing you about something, it sounds a bit like a command. Yeah, in a sense, but when another young person is just having a casual conversation about such, I think it could be it's less intimidating. Yes.
Beautiful. I was going to ask, what about BYs, right? Yes, no, a vote for BYs or not? There is? Okay, good.
I just want to add the comment that was made by the young lady at the back, and this is something that we have been having discussions about, and I'm proud and glad to see that a young person actually also has this in mind, because I think the rural areas have been somewhat lagging in every aspect, especially also when it comes to medicine or medication. I therefore would like to ask if the rollout of the door-to-door medication delivery could be rolled out to rural areas as well, because you'll find that I find that within our research area, a lot of young people or even parents are opting to move back to the rural areas because they cannot cope in the cities. They've either lost their jobs and things have become so expensive. So they move back to the rural areas, and sometimes with their adolescent children or children per se. So then that would then address the issues of them having to move from an urban area back into the rural areas.
I think so we've got 5 minutes left in this session, but the good news for everyone in the room is that Prof. Becker's chairing the next session. So she'll obviously just seamlessly bring any questions that are unanswered into that one. What I want to do is I've got a few direct answers to some of the questions, and then I want to turn over to each of our panelists to give some closing thoughts. So while I'm answering, please feel free to formulate those closing thoughts and what you want this group to take away from the session. So in regards to access of treatment, access to PrEP in rural areas, what's really unique, and so I showed like I'm trying to encourage South Africa through some other country positive peer pressure to have longer treatment refills. What South Africa is positively encouraging with other countries in Eastern and Southern Africa is the de-siloing of HIV. So we have guidance that is for HIV, TB, STIs, and NCDs all together, right? And so we see HIV in a more holistic lens within policy documentation. And South Africa's emphasis has been largely on expanding what are called external pickup points. So there's over 2,500 external pickup points outside of the Western Cape. Those might be cliques, they might be ShopRite, but they're also community halls, libraries, containers, community-based organization venues, community-led organization venues, and people can collect their medication from those venues, and not just their HIV treatment. So they can collect their HIV treatment, but they can also collect their NCD medication. And so what that is supposed to do in some ways is offer alternatives for people to have access to medicine closer to home in a way that is both packaged and integrated, so that it's not obvious what is in each package that every person is getting. And there's about 3 million people living with HIV who get their treatment in South Africa through those 2,500, 3,000 pickup points. And so the hope is to layer on more within those pickup points. So for example, to make sure we could have PrEP within those pickup points. And so we've really decentralized that way, because in a South African context with 8 million people living with HIV and many people who would stand to benefit from access to prevention, in a public health approach, door-to-door couriering was something that was put in place during an emergency response. It's not a sustained program, and it's not necessarily sustainable if you look at financing and all of the needs that we have in the country. So that would be my content takeaway. So I will turn to the group on my left, and who would like to give some closing remarks to this session first? Thank you so much.
So what I would like to say is that if as a person you have this virus, kind of virus, it's no longer a difficult thing to face, because it is now treatable. You can still get a new partner, let's say get a new partner, share love with a new partner, because there are high chances that that partner cannot be infected. So what I can say is that as us as young people, it was very, I'm telling about myself, it was very difficult when I found out that I had this virus, because there are 3 people in my life, a friend, a boyfriend, and a family. So it was very difficult to tell my family that I have this thing. It was very difficult to tell my best friend because I was afraid that I would lose her. But it was not difficult to tell my boyfriend because he was the only person that I was sharing love with. Do you understand? So it is also very difficult to get a new partner because you have to tell him. It is very important to let your new partner know that you have this thing. So that it is up to him that he's choosing you or he's getting someone else. So what I would like to say to us as peers is that the first thing that you need to do is to accept yourself. Yes, it's the most important thing, to accept yourself. Thank you.
Okay, as Abdul has said, she said that she's not the end of the world with HIV. And some people have lack of education about HIV. Because some of them, if I share a glass with Pamela, how much I want to do that with you. Yeah. And then they always need everything. And then I always tell myself, if I have self-confidence, I love myself, okay, what else think about me? Yeah, and I'm very confident about myself. I disclose with anyone if I feel like, because I want to get this out of myself, because we think that all the time, which is difficult. Because I'm always thinking, oh, I might die anytime. But no, that's not a thing. I have my treatment, I take it, I'm not suppressed, I'm okay. So having people such as counselors, Celine, Nonde, I want myself supporting me, that's good. I have my family, I have my friends. So I just want to thank you everyone that we've bought medication for us, because some other countries buy container of medication with a lot of money, not just 50 rand, with a lot of money. So I'm grateful for South African government to give us treatment for free, although some of us default, take them to open their pharmacy in their own. So.
From me, I think it's just to all of us sitting here that we really need to learn to consult with young people and not make decisions as adults on behalf of young people. We should really learn to speak to them and hear from them. How do we best serve them? And also to you, I agree with you when you say SRH is not fashionable, it's not on your television, it's not on your YouTube. Can young people make it happen? Can you create that? Can you start their podcast? Because when Pamela does it, it looks like I'm bullying you because I'm the bigger person, I'm the adult. So can young people take a stand and take initiative and start these things? Thank you.
I think riding on that wave, 100%. I go back to a poem that was done at the International Workshop of Adolescents in HIV, where it was adolescents are not in the box, right? But thinking outside the box when you're also not in the box, when you're in the box is difficult. So it goes back to that, involving them in that, brainstorming stage, in that discussion, and, their voices then being the ones being heard. And we are then implementing what we've heard versus the old-fashioned way of parenting, where the elder people know best. I just want to reiterate that. And then I just wanted to comment on the question around the door-to-door medications, just to reiterate the options issue. I remember when this initiative was rolled out early 2020, and I was supporting a district in South Africa where we could not get traction. They were not interested. So I'm going back to that. It will work for others, it will not work for others. The more options that are available, the better.
Great. Thanks, everybody, for a great session. And we look forward to more engagement. And I believe that I will now be introducing an artist who is I don't have a printout of the briefing though. Just one second, I'm pulling it up here. Okay, so I am now going to ask Sobantwana, who is a product of the Valley of 1,000 Hills in a little town of Tsolo in the former Transkei. Her music is a fusion of electric soul, jazz, and with her strong traditional African harmonies, you can easily understand where her strong voice comes from. Welcome. Thank you so much.
Hello, everybody. Such a wonderful moment, such a beautiful day. Thank you for having me. My name is Sobantwana. I also work for Desmond Tutu Health Foundation. Really a beautiful foundation. I have to, you're in front of me, remember? Whenever you're ready. The song I'm gonna sing is literally a prayer. It's a gift from my grandmother, my mother, and then it found me. And I do hope you'll enjoy it. Indaba zakhona zenziwa zizenzo zam abadala basakhuza esalaliwe andisalaliwe indaba zakhala zenziwa zizenzo zam abadala basakhuza andisalaliwe andisalaliwe kwaveli makhulu wathi vusa umzi wami zogqibela ngazo iintsimbi ezimhlophe iintsimbi ezimhlophe emathombo ovumaliwe thethani na ndifuna ndinenzele nina ndifuna ndinenzele emathombo ovumaliwe thethani na ndifuna ndinenzele nina obindlela zam ayazilunga ndifuna ndinenzele nina ndifuna ndinenzele nina awunempilo yam ayilunga ayilunga ndifuna ndinenzele nina ndifuna ndinenzele nina ay 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 Thank you.
Okay, everyone, please go and enjoy some tea and coffee, refreshments, etc. And we'll try and start again on time at 11:20 if you can help us to do that. Thank you.